Let me invite the next speaker. Rather, he will have two continuous presentations. The first one is bariatric surgery with ventral or inguinal hernia. And it's a pleasure to invite Dr. Iftikhar Sumro. He is working at this moment at Rawal Hospital. I'm sorry for that. So, anyways, the stage is to you now.
चलेगा चल रहा है ठीक है बिस्मिल्लाहिर्रहमानिर्रहीम अस्सलामु अलैकुम व रहमतुल्लाहि व बरकातुहू. Thank you very much, Dr. Rizwan, for giving me the opportunity to talk on the controversial issues. And everyone has a big idea on this hernia. Everyone is a very good surgeon of hernia. And second talk is more dangerous than this. So this is how the patients you can present with this. Management remains controversial. There are three main things. Number one, repair before bariatric surgery, concomitant or simultaneous repair, or delayed repair after weight loss. So we will review the epidemiology, discuss current evidence, compare operator strategies, and present recommendations. Number one, we should know how the hernia forms. Mechanism is increased intra-abdominal pressure, poor collagen metabolism. Patient who are obese, they mostly have the diabetes as well, chronic inflammation, impaired wound healings, and higher recurrence rates. So these are different types of hernia you can encounter. Everyone knows these are in detail. And you can see in this map, but this picture is not of an obese patient. What are the challenges when you are repairing the hernias? Are thick abdominal wall, large hernia defects. You will not appreciate when you examine the patient. You will find it will be a smaller one, but when you will open, you will find the bigger defects over there. Difficult trocar placement again, high wound infection risk, increased recurrence rates, and loss of domain in most of the obese patients. These are a few guidelines we will discuss on this. If it is a small hernia, it's your choice whether you are putting 1 or 2 stitches to close it or leave it as it is. If large symptomatic ventral hernia, must repair it. And complex abdominal wall defects are there, please do not repair right now. First go for bariatric surgery. After weight loss, we plan for the surgery. So we will discuss bariatric surgery first. What are the advantages? Number one is easier late repair, because there will be no fat. You will have no any issue while doing laparoscopic or open repair, and lower recurrence rate because there is no intra-abdominal pressure, every fat and all obesity has gone away. Disadvantage is only 2 times operation, economical burden, do 2 times anesthesia like that. And there is another simultaneous surgery, bariatric surgery plus hernia repair. There's advantages is 1 anesthesia and single admission. It's cost effective. Disadvantage is longer operative time, and if the mesh is required, chances of infection are higher in these patients. Surgical option, hernia repair first, then go for the bariatric surgery. Sorry, I am doing this. Usually this is reserved. Most of the people don't want to do first hernia, then bariatric surgery. And if you go for hernia first, chances of obstruction, strangulation, and large symptomatic defects are there, and it will be difficult to close them. And if you are using the dual meshes, those are expensive one as well. So this is a main plan how you have to do. If hernia is symptomatic, yes, repair with bariatric surgery. If hernia is not symptomatic and is bigger one, wait. First go for bariatric surgery and repair after when the weight loss will occur. A hernia defect size is less than 2 centimeter. Repair only with stitches. When mesh is required, think twisely and try to not repair it. First do bariatric surgery, let the weight be lost, and then repair it. The data suggests concomitant approach appropriate for hernia that surgeon feels do not require mesh, while the staged bariatric surgery first approach is more appropriate if the hernia requires mesh replacement. So this is a most authentic metabolic bariatric surgery accreditation and quality improvement program database, in which nearly 430,000 patients were selected. Out of them, they have chosen 4,690 patients. They went concomitant ventral hernia repair with the bariatric surgery. What they found? Higher major complication rates, 5.8 versus 3.8. When you are doing first bariatric surgery, then ventral hernia, then the complication rate is very lower than that of when you are doing concomitantly. And in this, when you are doing sleeve gastrectomy, 3.2 versus 2.4, and RYGB, these are more higher rates, 9.3 versus 5.7%. So this is a message for bariatric surgeons. Should consider these risks when choosing to perform ventral hernia at the time of bariatric surgery. And I have noted our surgeons say, okay, I will do hernia same time, in the same price, but please, do not say anyone. Yesterday one case was discussed from other surgeon that he is offering we will do both at time. And sorry, first I will examine, then I will decide what to do. So again, there is issue primary repair or mesh repair. These are different techniques of mesh repairs everyone is aware of, and how we can say this is overlay. Inlay means bridging of the mesh, retrorectus, preperitoneal and intraperitoneal. Nowadays, laparoscopic surgeons love this because it is easy but expensive. So these are technical comparison of sublay, inlay and IPOM. Recurrence is higher in sublay 3.2%, at 1 year 4.2% at 2 years. Issues of seroma, surgical site infection and serious complications are also higher. And inlay mesh repair, recurrence rate, surgical site infection and seroma are higher than sublay as well. But IPOM is a very good procedure. Recurrence rate and seroma is similar, and surgical site infections are lower. Now what are the recommendations? Which operation should be chosen? Onlay, not recommended for bariatric patients due to high recurrence rate. Sublay, large hernias, post-weight loss and incisional hernias, you should opt this out. And IPOM best for concomitant with bariatric surgery, and if the small defects and you are planning a staged repair. Again is the issue of mesh selection, synthetic mesh or biological mesh. Synthetic meshes are durable with low recurrence. Infection risks are there. For biological meshes, this is a you should use this in a contaminated field. If contaminated fields, you cannot use these synthetic meshes. Disadvantage is it is a very expensive and higher recurrence rates. Inguinal hernia you can operate with bariatric surgery or before or after, mostly there are no issues in this. So what are the future directions for this in the future? As already announced, there is a robot over there. It prepares enhanced recovery pathways, AI-assisted surgical plans, 3D abdominal reconstruction and plan how to operate, and long-term registry data which will guide in future. Key messages are there. Obesity increases hernia incidence and recurrence. Management should be individualized. Simultaneous repair is safe in carefully selected patients. Large complex hernias often benefit from staged treatment. Multidisciplinary decision making optimizes outcomes. So these are my references. Most are from the IFSO and American Society of Bariatric Metabolic Surgeons and all others. Thank you. मेरी दूसरी प्रेजेंटेशन लगा दो.